Hello, Dr. De La Torre. How are you?
Good morning, Ray. Can you hear me?
Perfectly, yes.
Okay. They changed the computer yesterday, so I'm not sure if it's working properly.
Seems to be
I
working
hope
fine.
it's working.
It seems very good. Yeah, much clearer. It's a much better camera video.
The audio is not very good.
Really? I can
Yeah,
hear you
because the
very
audio is
clearly.
in the computer and the computer is in the floor,
Yeah. Oh,
so it's really hard to hear.
oh, I see. Yeah.
So probably I'm going to move to my MacBook.
Okay.
Yeah, because I I can hear you, but very, very low.
Oh, that's not good because I'm actually very loud on my screen.
Yeah, it's very difficult to hear. I'm going
Okay.
We
to
hear
log off
you
and log
perfect.
in again, okay?
Yeah, we can hear you, but you can't hear us. Yeah.
Yeah, I can hear you it's very low. Okay.
Okay.
Can you hear me, Ray?
Yes, perfectly. Can you hear me?
Oh, yeah. Perfect.
Is that better? Okay, good.
Thank you.
Good morning, everyone, and welcome to our monthly International Colorectal Web Meeting. Today, so far, we have pediatric surgeons joining from Russia, United Kingdom, Czech Republic, South Africa, Vietnam, Colombia, Paraguay, Nigeria, Mexico, Cameroon, Sudan, Indonesia, Iraq, and Trinidad Tobago. I hope I got everyone. Thailand. If not, please type in the chat and I will acknowledge at the end. And Algeria and Argentina. So our first presenter is Dr. Mikhail Gopienko from St. Petersburg, Russia. Welcome. I'm going to mute my microphone and you can share your screen.
Dear colleagues, dear Dr. Peña, Dr. Bishop, Dr. De La Torre, all the colleagues, thank you so much for such a great opportunity to present my case. It's a great pleasure and a great honor for me. I'm presenting Children's City Hospital number 1 in St. Petersburg, Russia, and we have a neonatal surgery team, and of course, colorectal patients are one of our most favorite ones. So the story of my anorectal malformation boy started in such a rather usual way as many others. There was a full-term boy with nothing peculiar on prenatal ultrasound, and at birth the doctors revealed that the anus was absent. This is how the perineum looked like. No evidence of any fistula or other symptoms suggesting the fistula. So he was admitted to our hospital at the age of 4 hours, and during the following 24 hours, we observed him, and there was an increase in abdominal distension. Something firm became palpable. We think it was distended colonic loop. Abdominal ultrasound showed mild bilateral pyeloctasia, about 6 on the perineum. There were no admixtures in urine. Of course, we inserted the urinary catheter at once and we observed the urine. It was quite clear. And we ruled out all the possible associated abnormalities, vector association. So after 24 hours, there were indications for X-ray investigation, and we did this prone lateral cross-table view. It showed rather great distance, more than 5 centimeters. But we thought that the picture was a little bit unusual, and so we would like to everyone to vote. What would you think? How would you interpret such X-ray? Just some high form of
I think we lost the image.
Yes, we've lost him, actually. Here he
Okay.
comes.
Do you
He's
have the
back.
presentation? Because
He's
maybe
back.
maybe we can put the X-ray.
Yeah, let me get the X-ray real quick.
So just give us 1 second while Ray is gonna pull the presentation so everybody can see the X-ray.
Hold on 1 second. Yep.
So, can you hear me?
Yes, we can hear you. Here's the X-ray, and this is what the poll is about.
Perfect. So while I think he's having internet troubles, can you put in presentation mode, Ray, and I can pass the slides until he comes back?
Okay, it's not in presentation mode.
No, we're seeing the side slides in one screen.
Okay, hold on.
But I think everybody was able to see a massively dilated sigmoid on the X-ray.
Something happened. Can you hear me?
We can
Yes, we
hear
can hear
you.
you.
I think Ray's trying to pull the presentation, but if you can share from your screen.
Can I go on?
Yes.
Yes.
Yes. Sorry for this. I don't know what was it. I'll share it once again. Okay. So,
Okay.
is it visible now? Yes.
It is visible, but we have the side
So,
present. Can you turn the side panels off, please?
as for us, we thought it was quite
Here we go. Perfect.
Okay. I think we
Okay.
lost you again. So
as for
okay.
us, we thought it was quite.
You're good. Go ahead.
Here's the results.
Yes. So can I go on?
Yes.
Yes, thank you. So we thought it was quite suggestive for congenital pouch colon because we were very impressed by this great volume of this gas field structure. So we went to surgery. We were quite sure we will find congenital pouch colon there. But when doing laparotomy, I'm sorry. Surprisingly, we didn't find any congenital pouch colon, and the diameter of the distended colon was no more than 5 centimeters. But what we found was the site of atresia at the very rectosigmoid junction. So there was sigmoid atresia. And there was also Meckel's diverticulum, which didn't play a role in this case, as we think, and we just resected it. But surprisingly, when we cut off this rectum at the site of atresia, we found that it wasn't unique, and there was another one some 5 centimeters deeper, 5 centimeters more distal. So in fact, there were at least two sites of atresia with two segments of blind ending rectum, more proximal one and more distal one. We opened both those segments and we decided to anastomose them together. At that time, we were not sure about the possible use of this part of bowel for some future reconstruction, but we decided to preserve them at least to have a possibility to perform the distal colostogram some days after. Still, the further way downwards, as well as possible connections with urinary tract, were unclear at that point. So we anastomosed those two segments, and we also took biopsies from three sites for some reason, and they all came pretty ganglionic. And we applied the double barrel colostomy. And in this case, we had to do it not in the way as Dr. Pena teaches us in the classic site, but at the site of this atresia. So it was unusual place of colostomy. This is how it looked like at the end of the surgery. The postoperative period was quite uneventful, and there were no GI symptoms ever after. The stoma worked pretty good. But at 3 weeks, there occurred some urologic issues. The control ultrasound showed us the increase of diameter of pelvis and calyces, and it was bilateral hydronephrosis this time already, with some resting volume of urine in the bladder. So our urologist decided to insert the permanent catheter for 1 month, but despite it, there was an attack of UTI 1 month later, which required hospital stay, antibiotics, and so on. And our urologist investigated thoroughly this patient, and urography showed bilateral hydronephrosis, more marked at the right side, and the VCUG was with nothing in particular. So our urologist told that there were indications for Anderson procedure at that time, at least the right side Anderson procedure. And here is the other question to vote. What to do first? Was it better to do first anorexoplasty or to start with right-sided Anderson procedure, or maybe it doesn't make sense to combine both of them at one time, or the order doesn't matter? So it was interesting what the participants think on this.
So there are the results.
Thank you. So this is the same decision which we made because we thought that the kidneys in this case were in some sort more important than anorectal region, and also for our procedure we needed to perform distal colostogram, and we were afraid that in case there still is some fistula, maybe we could provoke UTI and spoil all the surgical plans and so on. So we let our urologist go first. And at the age of 3 months, they performed the right-sided laparoscopic Anderson procedure, but we used it because when they did cystoscopy, we asked them to look thoroughly about the bladder and the urethra in terms of some possible additional orifices. And there was a suspicion of some additional orifice at the site of verumontanum. They could insert some thin tube there, about 1 centimeter in depth, but there was not 100% evidence of any connection with the colon. So as a result, we suspected possible prostatic fistula, but we were not certain. What is today? Today, the boy is 5 months old, and at last we did this distal colostogram, which showed us that the total length is about 13 centimeters. There's no evidence of fistula because there is pretty round shape of the bottom of this rectum. The distance from anal dimple is about 3 centimeters, and the distal point is well below the coccyx. And the diameter of this rectum, when filled tightly, is up to 1.5 and even 2 centimeters at some points. So this leads us to a couple of questions which we would like to discuss. So the first is about the fistula. After all what we have done, after all what we have seen, can we still be sure it is absent? If yes, then what to do with this cystoscopy data? Maybe just ignore it, maybe it was just some sort of misinterpretation by urologists. Then can there be maybe some more complex malformation that we think? Maybe some third atretic rectal segment connected to the fistula. Sounds crazy, I admit, but the very case is so unusual that who knows? And in terms of this, does it make sense maybe to repeat cystoscopy during our anorectal repair? And the second major question concerns best surgical option. So does it make sense to use that distal rectum for anorectoplasty, or we would better sacrifice it and pull through the proximal sigmostoma? And whatever we choose, can we understand that there can be situation when we will get rid of the stoma, and in this case, will a new ostomy be needed? And what is the better choice, the colostomy or ileostomy in this case? Thank you very much. This is our team.
Thank you very much. I think this is indeed a very interesting case. I personally have never seen one of this. So I think when you ask what to do, nobody will be able to say, oh, in my last 10 cases, I did this and it worked. So I'm going to say in retrospect and with the information that we have now. So regarding clarification of the anatomy, I think a good pelvic MRI may show you if there is additional structure between that rectum that you connected and the bladder. And if it doesn't show anything, then I would say you can rest in peace. There is no connection or there's not a third atresia. So I think I would recommend a very good MRI, pelvic MRI, and explain to the radiologist what you're looking for so they can see the details of it. Now, if this baby was in front of me on the first time you have operated, I think I would have done an end colostomy, and I would not have tried to preserve that distal rectum. Just because there are two atresias, they were very small doing that anastomosis, I would have no guarantee that it would work. But in retrospect, what you did seemed to have worked because the distal colostogram shows a good sized rectum. So at this time that the choice has been already made, that the baby has a colostomy, I would try to pull through that segment as an anoplasty. Now, the only thing we have to be careful is that sometimes in those atresias, the blood supply is different. So when you mobilize, if you have a dead bowel that arrives in the anus, then it's not worth doing. So I would go in the next surgery with a full bowel prep and prepare to take the colostomy down if trying to bring this distal rectum down doesn't work because of abnormal blood supply, because of previous surgery, because you don't have length. It's definitely a different type of bowel, probably different blood supply. So I don't know how it will be to mobilize and if it will arrive at the perineum with good blood supply and without tension. So I would go prepared to do the anorectoplasty from below, but if you don't succeed, at the same time you resect and you pull through the proximal stoma. Now, regarding the decision about separating the kidney surgery with the anorectoplasty, I think this is absolutely the right decision. You didn't even have the information. There's a chance you will be able to do everything posterior sagittally, so it would be completely different surgeries. So very interesting case. I'll let Dr. Pena comment.
You know, your patient is not going to die from colorectal problems. Your patient, if he dies, is going to die from renal function. So at this point, I'm still very concerned about the renal function because you show a picture with ureteral kidney ureteral obstruction, an obstruction of the kidneys. Those kidneys are not draining well. So that's the priority. You have to be sure that the kidneys are decompressed to see how much renal function they have. And patients born with bilateral hydronephrosis end up in kidney transplant later in life. So the real emergency in your baby is to decompress the kidneys, either by anastomosing the kidney pelvis to the ureter so they can drain, and then keep monitoring the renal function. Once the urinary problem is solved, then you can go ahead with the rectal problem. He can stay with the colostomy for a long time. There is no urgency, but the kidneys, to me, look like an emergency.
Thank you so much. Thank
Go
you so
ahead.
much. Could you, yes, what about the additional stoma? If we pull through this one, the current stoma, what about, would you apply another one?
In the way from the colorectal point of view, the way I would approach that, as Dr. Bishop said, I will enter to the operating room with the colon perfectly clean, all the colon, all the intestine, to have alternatives to be used whatever is necessary. I will start posterior sagittal to see if you can, because you mentioned that the rectum is below the coccyx. So I will find the rectum and try to mobilize that rectum down. You may be able, you may not be able, and you may find that the blood supply doesn't allow that, and he may get lost. And then if it doesn't reach posterior sagittal, I will go into the abdomen and I will take down the mucous fistula of the colostomy. And by doing that, certainly you will be able to pull that rectum down. The question is, yes, you pull the rectum down, but is it still alive? Does it have good blood supply? Because this is not a regular malformation. I don't know the blood supply of that rectum. And if you lose that, that's it. Then you take the colostomy down as a new rectum. And now, if that rectum reaches the perineum, but but you will be it will be located very down in the pelvis, in the very lower, and then the colostomy closure may be very difficult because you have to anastomose down in the pelvis. So if that's the case, then you have to make a decision. One decision is to make the anastomosis, take down the colostomy, the proximal colostomy, make the anastomosis and pull everything down. And then it's up to you if you feel like doing a more proximal colostomy or not.
Or ileostomy. Yeah.
It's
Very good. Excellent case. There is a suggestion during the cystoscopy to try to push contrast. I think the MRI would be an easy way to rule out the fistula, but that's what someone else is suggesting.
and by the way, we saw the picture of your beautiful hospital. This is the first time that we see somebody from St. Petersburg presenting in this meeting. We look forward to see you more often, yes, and invite all the pediatric surgeons from Russia, because we scientists, doctors, and artists have communicate always all over the world, see, beyond politics and economics.
Thank you so much. Thank you.
And there is another suggestion, if indocyanine green could show the irrigation of the distal rectum. I don't have experience with that, so I cannot comment on that. Thank you very much. We're now going to go to the second presentation that will be done by Dr. Adriana Castrillon, pediatric surgeon from Colombia that is currently visiting us at Children's Hospital Colorado. Go ahead, Dr. Castrillon.
Hi, good morning. I'm going to share my screen now. Okay, can everyone see the presentation now?
Not yet. No, you have a
Not
beautiful
yet. We're
background.
seeing a lot of
Okay.
okay,
Here it
now
is.
we are.
Okay,
Perfect.
yes, okay. This is a case I got to observe while I was in my observership here at the Children's Hospital. This was a female newborn that was admitted to the neonatal ICU due to respiratory failure and seizures, who also failed to pass meconium. This is the abdominal X-ray on the 5th day of life. Here we can see that there is bowel distension and absence of distal gas. This is the AP view, and this is the side view of the X-ray, which correlates with the previous findings, the bowel distension and the absence of distal gas. So with this X-ray, which would be your next step, one, an upper GI to rule out malrotation, a suction rectal biopsy and contrast enema to rule out Hirschsprungs, or I don't know. Now we have the answers of the poll. Most of you chose the suction rectal biopsy and contrast enema to rule out Hirschsprungs. This would be our next step. However, here in the United States, it's always mandatory to do an upper GI to rule out malrotation. Here is our patient's upper GI, which you can see is normal. We can see the stomach right here and the duodenal C crossing the midline, which shows there's no malrotation. After this upper GI, this patient was taken to a suction rectal biopsy that showed absent ganglion cells and a single hypertrophic nerve. And this is her contrast enema. Here we can see there is not a clear presence of a transition zone in any of these pictures. However, in this next picture, we can see a narrow colon and bowel distension proximally. With these findings, what would you do next? A primary pull-through, a leveling biopsy with stoma, or I don't know. So we have the answers now. Most of you chose a leveling biopsy with stoma, which is what was done with this patient. So she went to leveling biopsies and an ileostomy and mucus fistula was made. The biopsies showed absence of ganglion cells throughout the entire colon and up to the distal ileum where the ileostomy was made. Now, after doing the ileostomy, when would you do the pull-through? Once the patient achieves solid stool in the stoma at 1 year of age, at 2 years of age, at 3 years of age, or when the patient is toilet trained for urine and the patient accepts rectal irrigations, or I don't know. Okay, we have different answers. Most of you chose when the patient is toilet trained for urine and the patient accepts rectal irrigations. This is what is usually done in total colonic ganglionosis here at the colorectal center. And so now that she's 3 years old and toilet trained for urine, she was taken for the ileorectal pull-through. Here we can see a picture of her stoma. Here's the ileostomy. And right here, I'm not sure if the cursor is showing, but right here we can see the mucus fistula. This is from the day of the surgery. So the surgery started on a prone position. First, we put the Lone Star hooks in the mucocutaneous junction, and we can see the anal canal is preserved. Then we advance the hooks to protect the anal canal. And here in this picture, we can see that the anal canal is hidden and it will be preserved throughout the entire surgery. Here we can see the beginning of the colectomy with the anal canal preserved, and this is the colon being pulled. Here we can see there is still the preservation of the anal canal and a little portion of the rectum that will be anastomosed afterwards with the ileum, and then we can see we are doing the colectomy. Afterwards, the patient will be turned over in a supine position. This is the pathology specimen. Here you can see the entire colon and the distal ileum where the mucus fistula was made, and that in the previous pathology showed absence of ganglion cells. Then we did the dissection, the takedown of the ileostomy, and now here she is in the supine position. We pulled the legs up and we did the ileorectal pull through. You can see this is what was dissected from the abdominal portion of the surgery. And finally, here we can see the complete ileorectal anastomosis with the preservation of the entire anal canal. For the postoperative care, we here at the colorectal center leave the patient 7 days on total parenteral nutrition with nothing by mouth. The patient will be discharged on rectal irrigations and flagyl 3 times a day. Then she will come to clinic at 1 month post-operatively, where a digital examination will be made at the visit to determine if anal dilations will be needed. And at the same time of the visit, the irrigations will be decreased to twice a day, as well as the flagyl doses. This is the case. The patient is doing very well and starting her feedings after 7 days of total parenteral nutrition. Thank you.
Thank you very much, Dr. Adriana. So I'll let Dr. Peña comment this case, but I think what I want to emphasize is the importance of being toilet trained and accepting rectal irrigations. So I will only operate on this patient if they bring the patient to clinic and I can watch the parents doing a rectal irrigation without the child fighting. I think this is a very important concept because those patients need irrigations, and you cannot have a child or a fight every time an irrigation is needed. You want to comment?
Yeah. The our protocol now, Dr. Bishop protocol, is not observed all over the world because pediatric surgeons have a tendency to go into a race. If you operate on a baby at 1 month old, I will do it 2 weeks, and another one will do it at 1 week, and then the other newborn, and then the other in utero, because they want to be recognized as doing things earlier. They want to discharge the patient very early. They want to do this operations without stomach. Everybody's competing by that. I am not sure if all that is on the results in benefit of the patient, and that's why we are very conservative. I have seen many patients with total colonic ganglionosis, and total colonic ganglionosis is a very serious condition. Doesn't matter what you do, it's a serious condition because we are removing the entire reservoir of the baby's bowel. So the baby will always have liquid stool. So liquid stool without a reservoir, in other words, connecting small bowel directly to the anal canal, will make the patient very difficult to control. Even if you perform the same operation in an adult, adults have to be very much aware all the time that that the bowel is trying to empty liquid stool. So you have to be you must have a very good continence mechanism. So and that's why the operation, the connection between the small bowel and the anal canal must be performed in an extremely meticulous way to be sure that we preserve the anal canal for sensation and that we preserve the sphincter mechanism. And so, and if you leave the patient without a baby, 1 month old, 2 months old, without the stomach and total colonic ganglionosis with no colon, the patient will develop the worst diaper rash that you ever seen in your life. A diaper rash that is impossible to control. The baby will not try to hold the stool because it's a baby. So they will keep passing liquid stool constantly, and those patients suffer a lot. We have seen patients coming 2 or 3 years later that were operated in another place where they closed the ileostomy very early, and the surgeons were very proud of being closing the ileostomy very early, but the patient suffers a lot. And that's why we decided that we will only close the ileostomy when the patient is toilet trained for urine. Being toilet trained for urine means that the baby already knows where the toilet is. He already knows what means to pee, what is not to pee. He already knows how to tell the mother that he wants to use the toilet, and is happy because he's been completely dry in the diaper, in the underwear. And then the other thing is that total colonic ganglionosis babies suffer from enterocolitis more frequently than other types of Hirschsprung, and therefore frequently they need irrigation. Most of them will need rectal irrigations to fight the enterocolitis. And therefore, if a baby has a severe diaper rash, has been suffering, the baby doesn't want anybody to get close to his bottom, doesn't want to do any maneuver. So you try to do an irrigation in a baby with severe diaper rash, it's going to be a fight, crying, the mother will cry, and so forth. Whereas if the patient has been completely dry and clean with the ileostomy, but is a happy child, you can pass a catheter well lubricated through the rectum, and the baby will not fight that because it doesn't hurt. So then you close the ileostomy, and if the baby needs irrigations, he will be willing to accept the irrigations. And therefore, the conditions to close the ileostomy is that the patient is toilet trained for urine, and that the patient cooperates to accept the passing of a catheter through the rectum. At that point, we are ready to close the ileostomy. And the surgical technique must be extremely meticulous in order for the patient to have bowel control.
Dr. De La Torre, do you want to comment anything about total colonic ganglionosis or this case?
No, everything is done. Congratulations.
Okay, so we're gonna now move to the next case that I will be presenting. Um, can you see it in presentation mode?
Yes, looks perfect. Thank you.
Wonderful. So this is a 3-month-old male patient that was referred to our center due to a perianal abscess. And this was the image that the pediatrician sent to us. So with this history and picture, what would you recommend? Nothing, because perianal abscess disappears after 1 year of age. Or see the patient and examine the anus, or I don't know. Everybody can vote. Very good. Always see the patient. So the patient came to clinic to see us, and upon examination, we were surprised to find a very tiny perineal fistula. So we decided to order all the screening. And again, this is a 3-month-old, but if you look at the x-ray, it could well be the x-ray of a newborn because we see this dilated rectum and not much down below. But this is at 3 months old, just showing the compression of the muscle and the fact that the baby has a rectoperineal fistula. Has a perineal fistula at 3 months of age.
Yes, but no, the instead of anus, you get a fistula.
Has a perineal
If you just
fistula.
said rectoperineal, they would say there is a normal rectum with a rectoperineal.
No. The patient has a rectoperineal fistula,
Malformation.
anorectal malformation, and the area where the pediatrician referred because of an abscess, I could see a tiny hole too. So it was a perianal fistula with a perineal fistula. So this is the x-ray. So the baby had a good sacrum. Here are the kidneys. So normal kidneys. No tetrachord. There was an incidental finding of a filler cyst. And here is the image. You can see that there is a perineal fistula, and this is the hole that sometimes the mom said this area got inflamed. So the reason why the baby was sent to me was because of this area, but actually there was more than just that area. So here we pass the lacrimal duct probe, and this opening opened at the rectoperineal fistula. So what we did was we unroof on top. We used the Bovie and we opened this fistula tract, and then we could see the rectoperineal fistula. We placed multiple 5/0 silks, and then it became just a case of a rectoperineal fistula. So we opened posterior sagittally, dissected the posterior rectal walls, the lateral walls, separated the anterior wall, did the anoplasty, and closed the perineal body. And that's the end of the operation. I just thought this was interesting because it was a case of a perianal fistula with a rectoperineal fistula. We have seen variations of this case, but one is not exactly like the other. There is a question about the other case. I don't know if Dr. De La Torre is there. There is a question about what's your take on the Duhamel procedure in a case of total colonic Hirschsprung?
Well, the Duhamel procedure, as you know, you need to leave the aganglionic rectum. The worldwide idea that I can say is when the Dr. Lester Martin did the surgery doing the colonic pouch, he used the Duhamel procedure. So in the in the world, the pediatric surgeons believe that the most effective type of pull-through in patients with total colonic is Duhamel, just because Dr. Lester Martin used the Duhamel. The problem of the Duhamel is if you don't do a good Duhamel, a very good Duhamel, then you will have obstructive symptoms. And in patients with total colonic will have even more. So I believe my recommendation is not to do Duhamel in total colonic. I know that many surgeons in the world are expert doing Duhamel. And if your patients are doing well, that's good. Just for surgeons that they are not doing Duhamel in the world, that they are doing Suave or Swenson, and they have a total colonic, I do not recommend to do Duhamel. Again, Duhamel is in the mind of many surgeons just because the pull-through with the Lester Martin, which was a big change, not a good idea, but a good idea, but not good results. Doing the Lester Martin, he used the Duhamel. That's my comment.
Thank you very much. So the idea of all those pouches is try to decrease the frequency of bowel movements. The problem is by trying to decrease, you create retention of stool. And in Hirschsprung, when you create retention, it generates enterocolitis. So that's why we prefer straight ileorectal pull-throughs. There are two more questions. One is a very interesting one because I thought the same thing. In the case that I just presented, if it was a type of a bucket handle, and then it create that fistula, I think it could be. There's no way to prove one way or the other, but I had the same impression that this tried to be a bucket handle and somehow it developed a fistula there. And the other question was, why doing rectal irrigations in total colonic ganglionosis? I think as Dr. De La Torre mentioned, as Dr. Peña mentioned, those are the patients that suffered from the highest rate of enterocolitis. So we do it in a preventive way. We don't want them to be discharged and come back with an episode of enterocolitis. So during the first 3 months, we are very aggressive in prophylactic irrigations to avoid enterocolitis. So in the first months, I send them home doing 3 rectal irrigations a day and flagell 3 times a day. They're doing well. The second month, I decrease to 2 times a day. And if they're doing well, the third month, 1 time a day. And then we stop. But anytime they have an episode of enterocolitis, they will restart the protocol. Enterocolitis is something that we see at the young age. As they grow older, we don't know why, it disappears. We don't see a 16-year-old with enterocolitis. So that's why we're very aggressive in this initial postoperative care.
So the person who asked why to do irrigations in enterocolitis, because enterocolitis in Hirschsprung disease is a kind of mysterious condition. If you want to become world famous, find out exactly the origin of enterocolitis and the cause of enterocolitis. So we don't know exactly why the patients have enterocolitis, but we do know some things about that. We do know that there are some proliferation of bad bacteria. And also we know that retention or stasis exacerbates enterocolitis and promotes enterocolitis. So by emptying the rectum, the best treatment for enterocolitis is irrigation. You know, irrigation means is very important because some surgeons, unfortunately, are confused about the difference between enema and irrigation. Enema means introduction of a volume of liquid, irritating liquid in the colon, so the colon responds by contracting and emptying. That's an enema. Irrigation means to pass a catheter in order to decompress the lumen of the bowel. Liquids, irrigation means can be done only when the patient gets liquid stool. So the liquid stool comes out through the catheter, and then we pass a small amount of saline solution through the catheter just to be sure that the lumen of the tube is empty. So the patients benefit from enterocolitis because you drain the stool. stasis. When the stool stays there, it promotes bacterial proliferation and enterocolitis. So when we used to do these operations, we discharged the patient from the hospital, but we made the mother paranoid against enterocolitis. I used to tell them, if it is, let's suppose that it's Friday afternoon and your baby has suddenly fever, abdominal distension, and vomiting, you go to the hospital right away. But before you leave to the hospital, you do a rectal irrigation. Because if you go on a Friday night to a hospital, you may find in the emergency room doctors that they don't even know what enterocolitis means. So in fact, at children's hospitals, pediatricians frequently believe that enterocolitis is the same as gastroenteritis, and they treat it like any other gastroenteritis, but they forgot to decompress the bowel with irrigation. And therefore, they tell the mother, you first do the irrigation, then go to the hospital, and then call me because I will tell you what to do. So the mothers leave the hospital with the catheter and saline solution ready to do, and have learned to do irrigation in the hospital, so they are very familiar with that. And the patients with the total colonic have more enterocolitis than other patients. But as Dr. Bishop said, the frequency of enterocolitis keep decreasing as the patient keeps growing and eventually disappears.
Perfect. So now we're going to go to the last case. Let me just share my screen. Case 4. Can you see my screen?
Yes, we can.
So this is a newborn patient with no anal opening. And this is the abdominal X-ray after birth. So I just want you to look at this image carefully. With this abdominal radiograph, would you attempt a primary repair? No colostomy. Yes, no, or I don't know. Everybody can vote. And thankfully, most people said no. Very good. The spinal ultrasound showed a low-lying conus at top of L4 with decreased cauda equina nerve root motion consistent with tethered cord. So I selected this case because I thought the distension on the abdominal radiograph was spectacular. We always say you should only get films to make decisions after 24 hours because that's when the baby will have swallowed enough air to distend the distal bowel. So this is after 24 hours, and you can see how much more colonic distension you have, despite the NG tube. The NG tube decompresses the small bowel, but it does not decompress the colon. So you can see now where you have distal gas. And this is at 48 hours. Now we're seeing the rectum getting more and more distended, and that's when you should start to become nervous and not wait so long, because that's the time to do the colostomy. There's no lateral for this one. So this is the kidney ultrasound. We can see mild dilation. And here is the MRI. So I want you to look careful at the bladder and to look careful at the rectum inserting. I'm not going to show you where because there is a question of what malformation is this. So this is the distal colostogram. This was not done by me. This was originally not my patient. And I will explain what's wrong with this distal colostogram. So the first image, we're injecting contrast. Once we see that it fills the distal bowel, then we're going to turn the patient. And we like to turn the patient in perfect lateral, femur in front of femur. And here you can see one of the problems is that this patient, most of the x-rays were taken in oblique position. And that's not the ideal image for us because we enter posterior sagittally. So here you can see that it's in an oblique position. The pelvis is not in front of the pelvis. And you can also see that there is some stool here. That means that when the colostomy was opened, the distal bowel was not correctly clean. But what you do know is that you have enough distal bowel, you have plenty of bowel for the pull through. Now, question for you, what malformation is this? Rectoperineal fistula, rectourethral-bulbar fistula, rectourethral-prostatic fistula, bladder neck fistula, or I don't know. Everybody can vote. Okay, so we have everywhere, bladder neck, prostatic, bulbar. I would say in this case, I would accept answers between bulbar and prostatic. Okay, and we're gonna look back at the images so you can see. In this case, in my opinion, the distal colostogram was not done well, but here you can see this is the bladder, this is the rectum, and it's entering right here at the prostate level. The MRI was not done for this reason. The MRI was done because the patient had abnormal sacrum, tetrachord, so we wanted to rule out presacral mass. But this MRI actually showed very well the rectoprostatic fistula. And when we asked about primary repair, my recommendation is be very careful with primary repair. But if you have an abnormal sacrum, don't attempt primary repair. So this patient has an abnormal sacrum. Here you can see clearly that it's a rectoprostatic fistula. The distal colostogram, in my opinion, was not done correctly. You see a little bit of the urethra here. So in the distal colostogram, I would say it's between a prostatic and a bulbar. But again, it's not a perfect lateral film. So it's not the ideal distal colostogram. This was a rectoprostatic fistula. So here is the perineum of the patient. You can see that the sphincter is a little more linear. So when we open posterior sagittally, this is the sacrum. We found the rectum. This is the fistula. And I apologize because this is in front of the picture, but here we place multiple 5-0 silks on the hemicircumference of the fistula. We separated the rectum from the urinary tract, ligate the fistula, and did the anoplasty. In those cases, it requires significant mobilization, so the rectum arrives not as perfect color as other cases, but provided you have not injured the bowel wall, it survives and it heals very well. And that's the end of the anoplasty. But I think the most beautiful thing about this case was just showing the abdominal distension as the days progress, and that you really have to start thinking of a colostomy because we want to avoid perforation. Any questions or comments?
Yes, concerning the issue of primary pull-through procedure, primary repair with no colostomy. So we used to do that in patients with perineal fistula, patients in good health with a perineal fistula, newborns, or vestibular fistula, because we saw where the fistula was located. If the patient's in good shape and you have experience in the management of those, you can do it primarily without a colostomy. Now, to do this operation in other malformations, you don't know what malformation the patient has because the patient has no colostomy, so has no colostogram, so you don't know the malformation, so you are going to enter blindly. So that is an exploration. And I insist that babies with anorectal malformations should not be subjected to explorations. That's an adventure, and if those babies don't need an adventure, you have to operate on these patients being absolutely certain of what the patient's problem is, to enter knowing exactly the anatomy of the baby. And primary procedures without a colostomy without a perineal fistula, without a vestibular fistula. You don't know what you are going to find, and you may end up hurting the baby.
So there is a question if this case could have been approached laparoscopically. It could, but I think in this case, the posterior sagittal approach offers a better approach. So when it's clear, a prostatic fistula, a high prostatic fistula, or a bladder neck, then yes, certainly. But I think for cases that are between prostatic and bulbar, I feel that the posterior sagittal approach is a better option. Why did you wait 48 hours without putting a stoma since the patient has no anal opening? Do you recommend doing so? So we recommend doing the colostomy after 24 hours of life, after you have screened for all the associated anomalies. This case, if I'm not mistaken, the baby was born premature and had a cardiac condition, and I think that's why the delay for the 48 hours. But he was not my patient at that time. What do we do for tetrachord? So that when the patient has tetrachord, we send them to the neurosurgeon, and the neurosurgeon will most likely offer a detethering of the cord. Usually they do that before 1 year of age. I think I answered all the questions, so I would like to thank everyone for your participation. And I would like to remind you that next month, we will have a very special meeting. It will be actually a bowel management course. It will be February 25th. So please register. It is free, but registration is required. So register yourself, your team, your nurses, because bowel management is truly a teamwork. So again, just acknowledging all the countries that join us today: Russia, United Kingdom, Czech Republic, South Africa, Vietnam, Colombia, Paraguay, Nigeria, Mexico, Cameroon, Sudan, Indonesia, Iraq, Trinidad, Tobago, Thailand, Algeria, Argentina, Iran, Congo, Spain, Cyprus, Philippines, Pakistan, and United States. Thank you very much, and we hope you can join us on February 25th. Thank you.